Now, we are going to hear about the next steps for the Patient Protection and Affordable Care Act, steady sailing, or choppy waters ahead. Very good question and a challenging topic. To represent this, or to present this all-encompassing topic, is Regional Director of Health and Human Services for Region 8, Kim Gillan. Kim is a longtime healthcare professional in the state of Montana, and many of us also remember her long service in the legislature to the people of the state of Montana. She's worked tirelessly on emerging issues, and she is going to let us know what's going to happen next. Kim.
Thank you. Well, good afternoon, and thank you very much for the opportunity to participate in the annual Healthcare Forum. Of course, it's great to be back in the great state of Montana and also in Billings. And I'm here to talk about the Affordable Care Act, and let's face it, we are 3 weeks past the election, but for me, more importantly, 1 month into open enrollment, and that's pretty exciting given the hard work that I know that navigators and CACs are doing in the city of Billings. We met this morning, and I'll talk a little bit about that later. Over the last couple of weeks, I've done a lot of thinking and researching about my talk, and obviously the title and topic was selected pre-election. After the election, a colleague of mine in Denver asked if I would be canceling, and I said, while it may seem easier, really seriously, it's actually very important now to begin the discussion about, as both of our U.S. senators and congressperson have said, what has worked for Montanans, what has not worked for for Montanans under the Affordable Care Act, and to get into the discussion as to what is going to be the future. This is not the time to stand on the sidelines. Anyway, and it's a serious matter, but I have to start it with a little bit of levity because anyone who knows me from the legislature knows that I'm always up for a good joke. First of all, when I was discussing the Affordable Care Act with some of the, what I call in-the-know folks from both sides of the aisle, I was reminded by one of them about Mark Twain's remarks that the reports of my death have been greatly exaggerated. So possibly that is appropriate for the Affordable Care Act. Next, when it comes to the question and answer period, I did not want to be without a resource. So instead of having my cell phone up here to call Washington, I brought something that I think is even more appropriate, is my lucky 8-ball. So when you ask me questions, I'll be able to respond such things as, ask again later, not too sure right now, but we'll save that for later on. So anyway, thank you very much. I guess probably I want to start a little bit with some background. The fate of the Affordable Care Act is really a key topic, not just to the policymakers in the room, but it's of real interest to folks who were in the marketplace before and are currently in the process of either renewing or for the first time getting involved on the marketplace. The week before Thanksgiving, I was in North Dakota and South Dakota visiting a lot of open enrollment events and actually talked with some anxious consumers. This morning I met, as I said, with many of our navigators. What we're saying to them is that I first asked what they were hearing, and there are really strong numbers, but certainly I would not be correct if I didn't say there was consumer uncertainty. And for now, as you probably know, the Affordable Care Act is the law of the land for 2017. Some of you may have been on phone calls with Secretary Burwell, head of HHS, and really right now it's all systems go. Although I am not an attorney, as you all know, is that there are contracts in place from insurers on the 2017 marketplace, and so we are urging and encouraging consumers to come in and renew their health insurance, or for many, hopefully many young invincibles, to come in for the very first time. What I will say is that, yes, there are the headlines about what has happened. I think right now 83% of folks that go on to the marketplace in Montana, these are Montana-specific numbers, get some type of financial assistance. I think the number is around 80% of those, and I have the numbers with me, but 80% of those who go on to the marketplace, maybe it's 77, can get insurance with a premium of less than $75 a month. I think it's 80% can get a premium which is around $100 a month. We have around 59,000 folks who signed up last year for the marketplace, and with Medicaid expansion, it's my understanding there are another 60,000 Montanans that are taking advantage of Medicaid expansion. So it's sort of important to have those numbers within the context. 2 days after the election, my boss, Secretary Burwell, was in New York, and she was talking with the press about open enrollment. Secretary Burwell shared on several newscasts, which you may have seen, is that repeal and replace is a political slogan. The immediate reality is that the marketplace is, as I said, open for business in 2017. And there is also considerable bipartisan concern that consumer coverage not be disrupted immediately. As I stated, insurers are committed to the continuous coverage. Christine Brown, who's the American Health Insurance Plan chief, mentioned this in a recent interview, and also House Majority Leader Kevin McCarthy stated on the 14th of November, you wouldn't have everything shut down, you wouldn't take everything away. He went on to say that we'll work with the Senate to find the best structure without disruption. So I think that our new leaders, some have been around for a while, some are newly elected, are becoming to coalesce around a common theme that we want to minimize disruption, particularly since, as the Secretary likes to point out, that we are at the lowest rate of insurance coverage, the lowest rate of uninsurance coverage now. 20 million consumers are covered. 10 million moderate and middle income Americans have gained tax credits in order to help them with health care costs, and that the cost of employer-based health coverage, and there are around 150 million folks that are covered by that, has been moderated. So those double-digit increases that we've seen in the past are beginning to moderate. So what can I say today that has some definitive or can be helpful for those of you who are obviously concerned about the shape that the Affordable Care Act will take in the future and the factors that will likely play a role in the repeal and replacement? I'm going to use a phrase that we used in the legislature when we were talking about an issue and trying to ascertain who are the stakeholders. And we'd say, well, does that person have a dog in the fight? Okay, so I'm going to share with you who we think has a dog in the fight. And I'm not going to anyway begin to speak for what their perspective will be. But those who are already speaking out and are likely concerned about repeal and what the context of replacement would be, one, consumers. And we know that there are a lot of consumers that are already involved with the healthcare marketplace. Although in Montana, I have to give a little commercial, there are 14,000 people who are eligible for the marketplace, which means they're eligible for discounts, but they are currently getting insurance outside the marketplace. So that's important to know, is that there are 14,000 people leaving money on the table. Another key group that was involved before and will be involved in the repeal or replacement discussions are going to be hospitals and providers, many of whom have just begun to see some positive improvements in their bottom line, and that's from the benefit of folks having insurance coverage and increased ability to pay their bills. Then there are insurance companies who obviously are concerned not only about things such as risk pools, the ability to operate across state lines, but are also concerned about their finances. In the region that I work on, the 6 states, when the headlines were about people pulling out of the marketplace and that there were going to be 2 or 3 insurers, we laughed a little bit about it. Not that it wasn't funny, but in Wyoming they've only had 1 insurer for the last 2 years. So we didn't feel that major impact because we've always had states that had, with the exception of, say, Colorado, a few number of insurers. So the other folks that will likely have an input as to what goes on are those organizations that do projections on the cost associated with any changes, such as the Congressional Budget Office. And I'm not advocating for them, but I think that's kind of an important consideration because with every proposal that comes up, there's going to be a dollar sign associated with it, and those entities are likely, and there are entities from both sides of the aisle, to have an impact on what are the specifics of replacement, because they will be talking about the cost associated. And I could say now that, as you probably may or may not be aware of it, some of the dollars that have been saved have gone on to make sure that Medicare's financial viability has been extended. So there will be folks looking at those. The other important group I want to share, and I have no direct familiarity, but the Heritage Foundation is becoming a stronger voice in the ACA repeal and replacement discussion. And so what they have said recently is that right now there is no single replacement plan that people are coalescing around. And I think that that is true just because some folks have pointed out it took almost 18 months or 2 years to get the current Affordable Care Act together, and likely a replacement will have as many different voices joining in to that discussion. As you probably know, that Congressman Tom Price, who is a physician, was announced today as the HHS Secretary appointee, and that Congressman Price has had his own plan in perspective, I believe, since 2013, 2014. Also, Speaker Paul Ryan has a plan, and then President-elect Donald Trump campaigned on repealing the Affordable Care Act. So that's why I make the suggestion that there isn't a single plan, and it's my understanding that these are kind of a work in motion. Also, the sort of interesting news is that many of you, and I did not see this, I got an email on it, that along with the announcement from the President-elect Trump group that Congressman Price would be taking over HHS, they also announced that, and I apologize if I mispronounce this name, Seema Verma, who is from Vice President-elect Pence's Indiana. She worked on the Indiana Medicaid and Medicaid waivers. So although I know nothing about this particular person, I was encouraged by the fact that she came from the states, because I know that has always been a major concern of ours, is that what happens at the state level. And you know what, that reminds me. I forgot a very important group of folks who are going to have probably very loud, although they may be opposing voices on what happens with replacement for the Affordable Care Act, and that is the governors. The governors of our states, not only Montana, but there are 30 other states that have expanded Medicaid, and those are big dollars that are coming into the state, not only for health care coverage, but also have, in the case of Kentucky, increased the number of jobs. So the governors, I think the National Governors Association made an announcement last week that they expect all of the governors to be very, very interested and very vocal on what happens not only with the marketplace, particularly the governors that have state-based marketplace, but those who have expanded Medicaid. So I've sort of outlined who I think the big players are. The next thing is, what is the process for this? And this is where things are as equally, I won't say confusing, but there are a couple of different strategies that could happen. One is straight repeal. However, this is considered and has been termed the nuclear option because, and a lot of this I took from other folks, it has the potential to inflict considerable pain on consumers as well as providers. So that is one of the concerns about the nuclear option. And we're hearing from folks like Senator Brasso of Wyoming that he would prefer for a smoother transition. So that would be a straight repeal, and it could, even though it wouldn't affect the contracts of the 2017 marketplace, it could put a dampening impact on the consumers. And I have heard from the folks that are enrolling consumers that right after the election they did have a couple of people call and cancel their appointments, and then 3 or 4 days later that they actually called back and said, oh yes, I understand that the marketplace is really set for 2017. Another potential process for this is the repeal and replace. And that has a couple of different versions. It can be repeal and replace with some legislation for immediate replacement, but because there isn't a clear, and I don't mean this in a critical way, there isn't consensus at this point about what that replacement should be, that is unlikely to happen. The other specifics that we've heard about is something called repeal with a delayed effective date. So either all or elements of the Affordable Care Act could be repealed, but as we all know from the state legislature, it's not effective for, let's say, another 12 months, 16 months. I would assume that because of the contractual nature of the 2017 marketplace, it probably would not be, that effective date would not be during 2017. And I have to do a little bit of caution. These are all sort of what I have picked up. I am not reading from any standard talking points, of which I get many from the legislature. But because I'm a Montanan and I'm talking to fellow Montanans, I felt it was important to lay out sort of what I'm hearing. And if anyone has a different opinion, I would really welcome, not an opinion, but different ideas, and they're hearing different things, please feel free to share it. So then there is the issue of reconciliation. Now, reconciliation is a 4-syllable word for tampering or fixing something through the budget. The key about that is that the only items of the Affordable Care Act that could be affected through reconciliation are those that are related to the federal budget, and that is a much narrower group, such as the tax subsidies or funding for different aspects of the Affordable Care Act. So it's a narrower group, a little bit from what I've been reading, a little bit more, and what I know, a little bit more tricky, because tax credits are those things that directly affect consumers. So I assume there will be some reconciliation, but I can't tell you what the details are. It's just important to remember that it's only those things that deal directly with the budget. Anyway, the other thing is that ironically, when we started open enrollment which started November 1 and will end January 31st, there was quite a bit of discussion and concern about the stability of the marketplace, particularly with regard to the insurance companies. There was some folks who decided not to get into the market or withdraw from the market. Interesting enough, a lot of those concerns are currently being raised right now with regard to the discussion, because how the impact it could have not only on consumers but healthcare providers such as hospitals. So the issue of stability, even under a new administration, will still persist. Okay, so now we've talked in generalities. Let's talk about aspects of the Affordable Care Act which replacement and repeal are likely to address. One I think is interesting is substitution of the incentive to purchase and maintain health insurance coverage as opposed to a mandate. So something to do with the mandate. We know that's been highly criticized. The substitution would be incentivizing, which could take various forms. A couple of different ideas, and if you get a chance to visit Congressman Price's write up on his health care proposals, they differ a little bit from Speaker Ryan's, but that it'll talk about what the potential incentives are. This is another interesting one that the Heritage Foundation has been talking about, is a shift away from income to age as a determinant of both subsidies and or premium prices. Right now, as you know, under the Affordable Care Act, and I will screw up, is that if you're under 400% of the poverty level, you are likely to get some type of subsidy. I like to call it financial help. It's the advanced premium tax credit, not exactly the most easy term for consumers or for a navigator to roll off, but those financial assistance now are income-based, and they could shift to age-based. I would assume, and we've heard a lot of talk about, the reduction and or elimination of essential benefits, which could result in less emphasis on preventative care. As you know, there are 10 essential components that are in each that are required for any insurance plan that is sold on the marketplace, and so definitely those are probably in the mix. The issue, I think we've heard a lot about insurance plans that become sold across state borders. The interesting thing that we're hearing is from, as you may or may not be aware, and I think you're aware, that the insurance commissioner, and of course Monica, who's done a fabulous job and is a colleague of mine from the legislature, has pointed out that the level of oversight of insurers and insurance prices, it really varies among the states. And in our region, particularly, it's very I'm going to be diplomatic. It's far less restrictive than what we typically hear about from the East Coast. But we have a great resource here in Monica to talk a little bit. So the whole issue of selling insurance plans across the state borders assumes a federal mandate, but it also affects the state people. And so it's important that folks who are making federal decisions understand that there is not a one-size-fits-all solution for insurance commissioners. There is discussion about reprogramming Medicaid dollars away from the able-bodied, and as you know, under the Medicaid expansion provisions, that there has never been a requirement that you work. So there's discussion of that. Another thing is that they're talking about capping the tax exemption for companies that offer employee health care, and elimination of or changes to the Cadillac tax. The only reason I'm bringing that up is that it's kind of like a Jenga game. When you pull out certain things, you start pulling things certain out, and it could collapse. That isn't a criticism, but I was not even aware that the tax benefits that employers get collectively to offer health insurance, they get a tax credit which is upwards of, I think, $250 billion. That is a big chunk of change, which some folks are suggesting would be reprogrammed to other areas. So that obviously is not going to settle well with big business and big labor, but that's one of the more, I won't say obscure, but less talked about changes that we might see forthcoming, is some kind of changes to that cap or elimination of imposition of a cap on the tax exemption that companies now receive for offering employee health insurance. We've heard a lot about the return of high-risk insurance pools. That is part of the discussion. The discussion also includes beefing up health savings account for folks. So that these are items that you may or may not hear about. I talked a little bit about the governors. They're talking about block grants to states for Medicaid. Some of the rural states are a little bit concerned. I was in South Dakota. I'm not speaking for the governor of South Dakota, but sometimes block grants for our rural states may not always be the most advantageous. So that's something to look at. I would assume that the other couple of things that will be involved in any type of replacement are adjustments to the risk pool and the whole risk corridor concept. The other is the retention of the ability for children to stay on their parents' plan until they're 26. And then, of course, what we know is a big flashpoint is the issue of pre-existing conditions. I think there are 130 million folks that now are able to get health insurance. They had pre-existing conditions before and they couldn't. And I bring this up is because this is often discussed in the news as one of those issues that you would like to keep the, I won't say the allowance that folks who have pre-existing conditions are not charged anymore. That was a major change. However, if you keep that without some of the other aspects like mandated insurance, it has been said that that will have a negative impact on the risk pools, that folks who are the sicker will go forward and get health insurance. Those who are not sick may decline to get health insurance, and then insurers are very concerned about what that does to their overall premium setting and the risk pools. So it's likely that there'll be some continuation of the pre-existing abolition. However, I have recently this morning talked with someone and said that continuation of the pre-existing abolition could continue, but it would be conditioned based on the continuity of coverage. So if you continued your coverage, you could continue to have your pre-existing condition would not be a ding against you, but perhaps if you were a newcomer or you'd switched in and out, that might be a challenge. And then the other one I thought was interesting that I picked up over the weekend was new or different ways to measure affordability. When we heard the comments this morning from our two senators and from the congressman, that obviously up front was the issue of affordability. And so there is now some discussion about new ways to measure what is affordable. And as I spoke in the beginning, I've heard some discussion about the shift away from income-based to age-based. So it could be some criteria based on age. I don't know how, but I just know that these are the things that are being discussed. So one thing about Medicaid expansion, 31 states, some of those have been Democrat like our own state, some have also been Republican, as in the state of North Dakota, Arizona, a couple of other, Kentucky, Indiana. As you know, Vice President-elect Governor Pence was from a state that had Medicaid expansion. The reason I bring up Medicaid, obviously that's part of the Affordable Care Act, but also it's noteworthy that some Kaiser Foundation studies indicate that in those states that did pass Medicaid expansion, that premiums for the marketplace have been an estimated 7% lower. So the insuring of folks that were previously uninsured, Medicaid expansion eligible, perhaps has shifted the pool from what might have been the Affordable Care Act marketplace to the Medicaid expansion. We know that many of those people are perhaps have delayed health care that are on Medicaid expansion. They may be sicker, more expensive. Those folks are then shifted away from the pool of folks that are participating in the Affordable Care Act. And then there's some other things about the Affordable Care Act, and I could go on forever, and I don't want to speak forever. We all know that some of the regulations from the CMS have been a flashpoint for controversy. I know I look out and I see many people, we've had discussions on MACRA. Those regulations are in place, and they can be changed. I don't know what, and I have to be honest with you, I don't know what the timing is of this. As one of the folks said recently, I think it was the Insurance Commissioner of Washington State, he commented that there are so many different aspects of the Affordable Care Act, and that to expect a change of everything at once is perhaps unrealistic. But it's not unrealistic from a political viewpoint, which it probably could be unrealistic from a political viewpoint, but it's also unrealistic from the fact that there are so many different stakeholder groups that potentially could be impacted either negatively or positively by all of these changes. And I say that because something that Secretary Burwell has focused on, in addition to enrolling people in the marketplace, is the concept of delivery system reform. Now, I don't even hear any groans, and I normally hear groans. But delivery system reform is a change in the way providers are paid based less on quantity and more on quality. So some of those reforms are 1 to 2, maybe 3 years down the road. And the reason that they're important to consider is because they are helping, hopefully, curb the escalation in healthcare cost. And that has been one of the real criticisms of the Affordable Care Act, is that, yes, it's great that more people are getting coverage, but others have said, but did it really do anything to address the escalation of healthcare costs? So that's why some of the CMS regulations, and since most of them are like 1,000 pages, I would not be able to speak directly on those. But that is really a consideration, is what happens to those irregulations and in what time frame. So I want to go back to what the topic was: smooth sailing or choppy waters. Obviously, it's going to be choppy waters, and if I'd had a life vest, I might have it on right now. But I think, all humor aside, is that some folks, such as Michael Levitt, who was the former head of HHS. He's from Utah. He was the former governor of Utah, and very, very, very much involved in healthcare. And former Governor Levitt, who served in HHS, I think under President George Bush, he recently came out and said there is a real need to be here not to overreach and not move too far too fast. And I think that those are wise words from someone coming who has really played a lot of important roles that have been affected by the Affordable Care Act, and that being HHS, the governor, and he's also very much involved in healthcare, not only in Utah but in many states around. So I want to say that my other observation is that this is like a freighter, and for those of you who have ever done any boating or sailing, this is not like a 12-foot sailboat that can make a tack on a fairly sharp dime. This is a freighter, and in my opinion, it is going to take quite a bit for a freighter to make that change. And so if I can share anything, I think the observation is that this will be more of an incremental transition when you talk about actually what will happen. Not that will preclude some type of congressional action on repeal and replace. Just the reality of changing the course of something that is a fairly massive undertaking, whether you agree with it or not. So those are my expectations, or not expectations, those are my prostinations on what possibly could happen to the Affordable Care Act. Basically, it is the law of the land. For those of you who are involved in open enrollment, I would encourage you to encourage consumers to get health insurance. I talked with a group of folks today, and I said, well, how are the higher prices in Montana affecting the actual bottom line for premiums? And 3 people gave me examples that said they've had a lot of folks who come in very concerned, but because of the tax subsidies, their insurance rates are actually one woman, to name names, from Riverstone shared today that she actually had a consumer whose rates went down $50. So what we're hearing from the field is that although premiums have gone up, that with the tax credits that are based on income, that most people are finding that there is limited change in their actual premium dollars. Now that caveat is that is for folks who are buying within the marketplace. So we have a lot of things going on. It's certainly, anything I say today is what I've picked up. I've obviously been listening to a lot of different discussions going on. But perhaps the most important thing, and I really learned this not only being in the Montana legislature, but learned this as a Montanan by adoption, I guess, whatever, is that this is not the time to stay on the sidelines. These are important decisions that are going to affect everyone, and just encourage you, either through your organizations, through our great elected officials, both at the national and the state level and the local level, because I see lots of legislators that this is, in my humble opinion, less of a time for rhetoric, but a more important time for looking out where the rubber meets the road and making sure that any changes that are made, and yes, changes might be necessary, that we think about the long-term implications on our very important healthcare system. So with that, I am happy to take any questions because I have my handy 8-ball here. And more seriously, if you have any questions or comments or disagreements about what I said, please let me know, because I wanted to come here today and just be really frank about what we're hearing and what we're not hearing. And what we're not hearing is that The system is in place for 2017 in terms of the marketplace, and that is now the law of the land. So let's go forward, and even as for 1 year, let's make sure that those consumers who might not have had access to health insurance and health care in the past have an opportunity to get perhaps what could be some long overdue health care from all the great providers in this room. So thank you very much. Great.
Kim, I would like to hear a little bit of an expansion on the controlling costs piece. It's obvious that if the pool narrows itself to people who are sicker and others who are well are not part of the pool, that's a problem in terms of managing cost. What alternatives have you heard about that look at that cost side?
Okay, well, great. And Kathy Kelker, state legislator, wants to know about what I heard about the cost implication, I assume, of some of the potential changes. I think, first of all, and probably the most publicized situation is that President-elect Trump met with President Obama, and they talked about the issue of pre-existing conditions and keeping children on their parents' health plan until 26. That was talked about, and it sent a positive signal that President-elect Trump was very interested in that. That was day one's news. Day 2 and 3 is the discussion of the cost implications, but even before that is the issue of insurers and what the pool of potential folks might be, because folks who have pre-existing conditions are likely to have be a higher cost insurer, and they are offset by the young invincibles or the lower cost folks. If you remove the mandate, then there's really no incentive for folks who may feel they're healthy, then they won't be in the pool, and then that's when costs are likely to go up. I apologize. I did have some numbers that I didn't bring with me, and I can't cite off the top of my head, but it talks about right now the Congressional Budget Office estimate for what the cost of the Affordable Care Act is. I think it's $136 million below, and that, don't quote me on that number, it may be below what the original projections were. So that's a cost implication that will have to be considered, because some of those cost savings are then helping to maintain the long-term financial stability of Medicare, and that's why there were some initial cost. The other one is this topic of capping the tax credits that large businesses get for providing health insurance. That is, I think, $260 million or billion. That's a cost out there that some people are talking about removing that cap, or placing a cap on. Right now, employers can take this tax credit. There's some discussion about capping that because that's very expensive, and then reprogramming what could be considered lost tax dollars to backfill the subsidies, because the consumers who are buying health insurance, let's say the health insurance is $400, and when you have premium tax credits, it only costs you $78. That differential is now being made up by the federal government. Even if you want to eliminate that and put it into tax credits, and now I'm getting into my old tax ways, that chunk of change, is that going to be a refundable tax credit that people actually get dollars, or just a tax credit against their income? So that's why groups like the CBO and these other groups will be there, because these dollars that are in the Affordable Care Act will still exist. It just depends upon which side of the ledger they're going to be on. So that's kind of the cost situation. Does that help?
Hi, Kim. Carol Beam, Rocky Mountain Health Network. My question is more from a provider perspective. The Affordable Care Act, one of the initiatives is the Innovation Center, And a lot of the things that we're testing today, like Medicare shared savings plans and joint replacement bundles and all those, are coming out of the Innovation Center. What are you hearing about that part of the Affordable Care Act's future?
Thank you. And Carol brought up the issue of some of those non-marketplace issues that are initiatives that are part of the Affordable Care Act. I will be honest with you, I am not too sure. What I've heard is that the Innovation Center has always been very controversial. Some people would like to eliminate the funding for it. It's my understanding that could potentially be done, I'm looking to Senator Daines' person and on their head, could potentially be done in the budget reconciliation. And I'm not putting a value judgment on it. So in a budget reconciliation, those dollars could potentially go away or be reduced. The challenge is that these innovative models that hopefully will help with healthcare cost would they go away? They've just been underway for 2 or 3 years. What I'm sensing is that because of these vested groups that are involved in the Affordable Care Act, one being providers, is that the Innovation Center is less likely to be totally wiped out, might be reconfigured in something else, but under its current form, it might be changed and morphed into something else. A lot of people have felt, I'm going to be candid, is that it was supposed to be voluntary, that it potentially has become mandatory. So I would assume if there's some changes, it wouldn't just be the dollars, but just the whole depiction of whether and how you participate in it. That's what I'm hearing.
Kim, hi.
Oh, this is going to be a hard one. I don't know, I better get my 8-ball for this.
No, it's so good to see you back home in Billings, although briefly. My experience when we were going through the rate review process this year for the 2017 rate year was that according to the companies doing business in Montana's marketplace, the single largest driver of cost was the cost of pharmaceuticals. And that's not something that's just unique to Montana. Certainly that's something that my colleagues all across the country are talking about. And so my question to you is whether or not you are hearing any real discussion about any type of legislation at the federal level to begin to deal with that particular issue.
Well, and Monica and Commissioner Lindeen asked a really key question about the cost of drugs, which definitely has exponentially risen, particularly as more people who are sick may get access, which they wouldn't have had before, to some of the great medications that are making their lives not only livable but extending them. My perspective is that there was some discussion that after the election that the Big Pharma sort of breathed a sigh of relief because of candidate Clinton's discussion on pharmaceutical and sort of an implication of greater regulations on cost. I've not heard much about that discussion. It's still early, but it's a great point. What I have heard is that there is a push, either through legislation or through regulatory reform, to accelerate the rate of improvement for drugs, assuming that some of the cost associated with new drugs is due to the regulatory process. And that may surface as soon as, I don't know whether Congress is taking up today or later this week, what's the 21st Century Cures legislation that is bipartisan, and there has been discussion that some policy discussions or some policy implications about FDA and drug approval process could actually be put into that. I'm not too sure, but I just heard that in the last 48 hours. But thank you very much. And also, thanks for I'm going to use this as an opportunity with the Affordable Care Act. You know, even if you like it or you don't like it, the thing that Commissioner Lindeen has done, and I feel it's important to point out, she always gave the honest answer. And I think that that's what consumers really appreciate, is getting the honest answer, whether it's good, bad, or indifferent. So thank you for your objectivity with regard to that. Any other questions or any other comments from people who have heard something very different? Because I mean that seriously. I'd be very interested to know. Well, great. Well, look, thank you so much. I'm going to be around for the next part of the afternoon. And, it's really folks like you coming together and freely talking about this that is going to make whatever the next steps are better. And hopefully we can all be part of that discussion. So thank you very much.
Well, we would like to thank Kim for coming back to Regional Director Kim. We would like to thank you for coming back to Montana and sharing the perspective of your region and Health and Human Services, and a little token of our appreciation.
Oh, thank you very much.
Let's give Kim another round of applause.